Okay, so lecture 3 is all about assessment, diagnosis, and treatment. So let's begin. All right, so before we even go further, you'll notice that the language I use is assessment, diagnosis, and treatment. The first major piece is assessment. And what is clinical assessment? Well, this is it's a flexible, ongoing process to assess a child's emotional, behavioral, cognitive functioning. It also looks at environmental factors such as what's happening in the family, such as stressors in the environment, such as poverty, etc. All of these factors and how they play. And then it comes to sort of likely outcomes for a problem, also known as prognosis. But clinical assessment uses a systematic problem-solving strategy to help try and understand what the disturbances are, how the family and school environment play a role. Okay, so there are different approaches. The two general approaches are Idiographic and Nomothetic. So if you look at the word Idiographic, the root is Idiographic, right? So idio means individual. If you study personality, you have the same terminology. So you may have heard the term idiosyncrasy, which are the little quirks of a person. Idiographic is basically the unique features of this child and his or her environment. And so we're looking for what makes this kid unique. What are some of the factors that this child experiences in their home life, family life, or school? But we also look through the lens of a nomothetic. Now, when I say nomothetic, think normal distribution. So instead of looking at the uniqueness of the individual, we put the individual within the framework of the general society, what is expected. So when we talked about adaptation, we are comparing a child relative to what is expected of him or her at a given age or stage. So Idiographic looks at the uniqueness of the individual. Nomothetic looks at larger groups and how a child is supposed to perform relative to that group. Considerations that you want to pay attention to is that ethnic minority youth are at greater risk of misdiagnosis, largely because there has been a Eurocentric view of mental health. That is changing. The DSM-5 has gone a long way to try and change this, but you need to pay attention to cultural information, and this is beneficial in many reasons. One is to establish a relationship with the child and the family. So understanding where the culture stands with certain family members is important. You may have heard the phrase, it takes a village to raise a child, right? Well, it takes many different members of a family to raise this child, and you may even be interacting with grandparents or extended family. You also want to look at the child relative to their family unit. And sometimes you need to work on the structure of the family or the communication within the family. And you may need to motivate other members of the family to change. And that may be easier or more difficult depending on the culture you're working with. Understanding cultural norms is important for valid or appropriate information and accurate diagnosis. And then knowing the culture drives treatment as well. So there are culture-bound syndromes. I think I referenced ataque de nervios, which is an anxiety condition associated with Latin communities, which is very similar to panic attacks, but it's unique. And then you have to think about what's considered acceptable or unacceptable, normal or abnormal. It varies from culture to culture. So, gender patterns. So let's look at types of disorders and whether males or females have it more frequently. As I said, I believe in the first lecture, males and females have roughly the same predisposition for mental health conditions. However, the commonly reported disorders fluctuate across males and females. And there's general patterns. One is internalizing disorders are more common amongst females. Externalizing disorders are more common amongst males. A second pattern is cognitive disorders are more common amongst males. Affective disorders are more common amongst females. And you'll see that this fits this table in table 4.1. A lot of the either cognitive or internalizing disorders are males, and at mood or, let me say that again. You'll see cognitive or externalizing disorders are more common amongst males, and your mood and internalizing disorders are more common amongst females. And then some, there is no real significant difference between the genders. Okay, so the next thing you want to pay attention to is knowing child development norms. That's very important in understanding how the child is doing relative to the group that we were talking about. So individual symptoms or isolated symptoms don't really matter as much as age inappropriateness. So we compare, okay, these idiosyncrasies that I talk about as in isolated symptoms, let's put them to the side. Let's look at how this child is behaving relative to his or her peer group. And so you'll see age inappropriateness, that usually defines childhood disorders, and impairment, how they're functioning overall in school, with their friends, etc., is a very key consideration. Now, so purpose of assessment. Well, there are different purposes. The first step is a clinical description that summarizes a child's behaviors, thoughts, and feelings. That's going to drive the diagnosis, which is analyzing information and coming to some kind of conclusion about the problem. Then we have prognosis and treatment. This is after you have a diagnosis. How can we help this child? One is prognosis. Well, prognosis refers to, well, what's the likelihood of our interventions being successful? How can we help them? Well, we may or may not be successful. So certain conditions we have greater success than others, and certain times we talked about a sensitive period, right? So that sensitive period matters. So let's take autism spectrum disorders. 1 out of 2 kids on the autism spectrum will remain nonverbal, right? So the prognosis in general is poor, but if we intervene earlier, the prognosis gets better, if that makes sense. So treatment planning is usually unique. We have individualized treatment planning based on the symptoms of the child, and that's trying to increase the success rate. Okay, so let's talk about how we do it. So one process is called a clinical interview. And a clinical interview, it can occur in 3 different ways. It can be purely structured, unstructured, or semi-structured. I strongly recommend the semi-structured, but let me explain all of them. So a clinical interview provides data about the family. An unstructured interview is basically a conversational approach. And it's, you're having a conversation with me, and we're just talking. It doesn't even seem like there's an interview going on. However, I'm trying to collect data. So according to your book, most interviews are unstructured. I would argue most interviews are semi-structured, at least from my experience. But unstructured interview, you allow the client to take it wherever they want to go. A purely structured interview means every client gets the same questions. Now, a semi-structured interview is you have root questions or stem questions you ask everybody, but then you allow the client to take it anywhere they want. That's why I like semi-structured, is because I'm going to hit all of the domains of development or all the domains of your life, but it's going to make sure I cover everything and the uniqueness. These are usually much better. They're usually much more reliable. They're far less biased. So semi-structured interviews are the gold standard if you ask me. All right. So in a behavioral assessment, you evaluate thoughts, feelings, and behaviors. Usually we talk about ABCs of assessment. You want to observe antecedents. The word antecedent means comes before. So what was happening before the behavior occurred? Behaviors are what's happening now. And C, consequences, what happens next? What is the outcome of the behavior? And if we talk about behaviorism, if the consequence is desirable, the behavior is going to increase. If the consequence is undesirable, that behavior is going to decrease. So if you look at antecedent behavior consequence in a pattern, so the child is requested to go to school, right? And then the child complains, oh, my stomach is hurting, right? And then the consequence, the child stays home. Well, that is going to drive the kid trying to stay home more often. Another example, kid is bullied or teased at school. The kid's like, I'm not going. Now, the consequence is no teasing, again, school refusal. And you could read the other ones. I don't have to go through all of them. Checklists and rating scales. There are tons of behavioral assessment instruments. Checklists and rating scales are good because they're efficient. They're norm referenced, so we know what we're comparing you against, and really relatively cheap. The one that you'll see a lot is something called the CBCL, which is a child behavior checklist, and is a general profile of the mental health of a child. Another example we might do is parents report or observers report baseline data, and then they talk about what's going on. I always say if you're going to do assessment, you want data from the parent, you want data from the teacher, and you want data from the child. And that's so important because my experience is that without all three pieces, you don't get a complete understanding. More often than not, parents are going to report their child's behavior in a more glowing or positive light. The teacher, they're going to be more frustrated more often than not, and they're going to report in a negative light, and the child is going to tell you things about him or herself that you might not readily get. One second. All right. So recording. So you could collect data. These behavioral observations can be done by parents or others, as I said. The challenge is getting accurate findings, and as I said, the best way to do that is have multiple reports. Another way to do it is you could have a kid come into your office and do a role play simulation and watch them. The Childhood Autism Rating Scale is a powerful behavioral observation or checklist, but it also involves observation. You also could do psychological testing. Now, psychological testing is a series of tasks given under standard conditions. Now, the word standard means all examinees get the same series of tests under the same conditions. That's what it means to be standard. And you could assess knowledge, skill, personality, IQ, etc. And then the beauty of this is you can compare a child score relative to his or her peers or the norm group. One challenge in psychological testing is that historically it has been biased or culturally biased against minority groups. That also could result in some of the increased misdiagnosis that we talked about earlier. Issues that we see is race, ethnicity, culture, socioeconomic status. It's usually normed on white, middle-class America. And as a function of it, when you have minority groups, they may underperform. All right, so let's talk about test fairness, context, and development. So all scores need to be interpreted relative to other assessment information. One of the things I say, in order for me to feel comfortable with a diagnosis, or putting anything in my psychological reports. I need multiple pieces of information saying the same thing. So the results, I need, I call it, what's it called? Two pieces of information. We put it together, that now I have a trend. We also want to compare it relative to, well, what was your referral question? What were you asking questions for? You need to match your data to the referral question. Now, developmental tests are used for screening, diagnosis, and evaluating infants and children who show risk. Risk could be anything. In an infant, they may be crying consistently, showing colic. Well, colic is one of the number one risk factors for developmental delay. So you could identify it that way. Or they're nonverbal at a little bit older, or their speech is delayed, or their motor development is delayed, or they're just not performing in the classroom. Then these are all children showing some form of risk. So there are different types of assessment. There are things called intelligence tests. So these are used to evaluate intelligence and education. Now, what I will tell you is that if you were to ask me, well, how do I define intelligence? This is your ability to adapt and profit from experience. That's the general definition. But there's tons of definitions of intelligence. There's not one definition. If you study the research, the experts argue on it. So you have the standard intelligence testing movement, and then you have Howard Gardner, who says there are multiple intelligences, or you have Robert Sternberg, who has a triarchical theory of intelligence, but I won't bore you with that. The bottom line is that in terms of the psychological construct of intelligence, we argue on its definition, but the way we assess it, we usually communicate this with intelligence tests. And for children, the most commonly used is the WISC, which is a Wechsler Intelligence Test for school children. It measures abstract reasoning, processing speed, verbal abilities, fluid intelligence, etc. Now, there are other IQ tests. There's the WIPSI. This is for kids who are younger than 6 years old. 2 to 6, whereas the WISC is 6 to 16. You have the Stanford Binet, and then you have the Kaufman's battery. So that's IQ testing. We also have projective testing. So projective testing is more tapping into personality. But if I were to ask you certain kinds of questions, you might answer it in a way that puts you in a favorable light rather than a true experience. So projective testing asks things in a very ambiguous way, or in a way that there's seemingly no right or wrong answer. But it's useful in tapping into interpersonal conflict. So how many of you have heard of like figure drawing, like the house tree person test, or the Rorschach test, the inkblot test? These are all projective personality measures. So the child doesn't see it as right or wrong. It's just tapping into aspects of their unconscious. Other types of testing, we have objective personality measures. So we have the MMPI, the MMPI-A, we have the Big Five. Now, most of you know the Big Five. The mnemonic is OCEAN, which is openness, conscientiousness, extroversion, agreeableness, and neuroticism. And then here's the spectrum of 5. We also have neuropsych testing. Now, neuropsych, neuro is the brain, psych is psychological functioning. We tie the brain functioning to psychological functioning. Usually this is associated with language issues, memory issues, decision-making, personality, etc. So, diagnosis, classification. Well, what is classification? It's a system for representing the categories or dimensions of psychopathology. If you look in your book, the various series or chapters, these are the categories or dimensions. In terms of determining the best plan, as I said, we use both Idiographic, meaning look at unique to the individual, and Nomothetic, which is group norm approach. So we defined this already. So if we were to look at categorization systems, we rely on relative consensus. So a categorical approach is referred to as a classic or pure approach, and it looks for a clear underlying cause, right? And the belief is that each one is separate or distinct or different from the other. A dimensional classification means that there are multiple or it's spectrum-based. Now, I got news for you. If we look at disorders, some operate in categories where they're distinct and some operate based on dimensions. So let's get to the current way that we categorize disorders, and it's the DSM-5. The DSM-5 actually dropped the multi-axial system, but it does cover what used to be called Axis 1 and Axis 2 disorders. Axis 1 were non-personality or intellectual disability disorders. Axis 2 were personality and intellectual disability. And it does cover some medical conditions, which used to be Axis 3. Okay, so let's look at some of the issues, right? Some of the criticisms. So some people criticize the DSM, right? Because it doesn't look at complex adaptation or transactional experiences that children have. It also doesn't look at infancy and childhood as much as it should. And it also doesn't look at interrelationships as much as it should. So there are criticisms, right? So it's very important to understand that we're moving forward, but it's not a perfect system. And you better believe that there will be a DSM-6. So if there are criticisms, why even have a manual? Well, there are some benefits of diagnostic labels, right? One, it helps us summarize or order our observations, right? So it helps us have a framework of treatment. Two, it allows us to communicate with other professionals how we see it. So when I use the diagnosis, if I'm speaking to another professional, they get it. They understand, oh, this is major depressive disorder. There are a whole host of features that could look like, but it's still depression. And it also helps talk to parents and say, here are the symptoms that your child may experience, and it allows parents or caregivers the ability to understand or recognize the problems that their child may be having. So what are the negatives? Well, sometimes we disagree about the benefit of labels. Sometimes there could be stigma. Sometimes there could be a self-fulfilling prophecy as you see the negative effects that could occur or a child's view of themselves. So we did assessment, right? Whether it's psychological testing. We did diagnosis, right? That's, well, what's going on? We used DSM, even with its strengths and weaknesses. And now we have to do treatment. Well, what is treatment? Treatment involves interventions or strategies to try and address the current problem or alleviate symptoms or make it better. So treatment must be culturally sensitive. In fact, when you work with highly religious clients, you may have clergy as a cultural broker. And we'll talk more about that throughout the term. In terms of treatment, well, there are ethical and legal considerations. We're required not to only think about the actions we'll have on the children that they see, but the relationships and responsibilities with the parent. One of the issues, a dilemma when working with children that comes up a lot is the fact that you're a mandated reporter. And this is tough. This is tough when you're working with a kid and you feel like you have to report suspected child abuse, neglect, or maltreatment. I do it. I do it very rarely, but when it happens, I do weigh the impact of the report on the parents as well. And I know that having ACS in the house is challenging. But we have a responsibility. We're a mandated reporter. That means even though I know that this may or potentially could cause some pain to the parents, I'm required to. Otherwise, I could lose my license. The way I do it is I usually tell the parents ahead of time. I usually call the family in for a meeting, and I explain to them, listen, your kid hasn't gone to school in a month, and that's called educational neglect. Or your child is using drugs and you're not doing anything to stop it. Now, if the parent is doing something to stop it, then I won't report it. But it's tough. It's really tough. But you have to balance your ethical and legal responsibilities there. Okay, so treatment. General approaches to treatment. So most clinicians take what's called an eclectic approach, which basically says, look, there are many intervention styles and approaches, and you cannot treat a one-size-fits-all. So CBT, as much as I say it's the gold standard, doesn't work with all patients. So you have to have multiple approaches. And being eclectic means that you have multiple approaches. In my own treatment, I use 3 approaches with my clients. So I use CBT, but I also use psychoanalysis because I'm aware of the importance of early childhood experience and how that affects the view of the self. And I also use humanistic or existential models. So I put 3 approaches together. So I'm within that 70% of clinicians. But what are some approaches? Well, psychoanalytic or psychodynamic approaches focus on the unconscious or conscious conflicts, the view of the self, early childhood experience. Behavioral approaches focus on just re-educating a person and saying, hey, these are appropriate behaviors, these are inappropriate behaviors, and in undergoing a behavior modification plan. Cognitive approaches look at, well, how do you see the world? What are some of your thought processes? And what are some of the errors in thought processes that you may have? And let's work on changing them. So those are general approaches. Now, CBT combines both cognitive and behavioral approaches. So the next bullet, as you see, just links the 2 of them together. As I said, there's a humanistic or existential approach. You may hear it said in different books as client-centered, usually Rogerian therapy. So now we're trying to be supportive and empathic, and we're trying to give the child unconditional positive regard. A lot of problems occur because children are taught what Rogers refers to as conditions of worth. I only love you when you do A, B, C. And that's tough. So as a therapist, we are trying to give this child unconditional love or unconditional positive regard and embrace the child for who they are as they are with no strings attached. That is huge in increasing growth. We also have family systems model. So again, anytime you're treating a child, you're treating a family. And you better believe that there are a lot of family issues. We also have biological or medical models. While here we're looking at pharmacology. So the child is struggling, therapy is not working in isolation. We might add a medicinal piece, right? Or we might, as I said, take an eclectic approach which combines multiple forms of treatment. So, is therapy effective? Well, the answer is yes. In general, therapy is highly effective. And now, which one is best? Well, here's the deal. Researchers have found that each intervention style works roughly the same. So treatments are roughly the same if you use CBT, psychoanalysis, humanistic. Some will work better for some individuals, and some will work for specific disorders. But if you take all disorders and put them into one pot, psychotherapy is roughly equally effective. And I say this because there's criticism to psychoanalysis because they have not done as much of the research on their therapeutic model. But the research that has come in suggests it works. It works for both internalizing and externalizing disorder. It's usually long-lasting. It's pretty solid. And then the more therapy a person gets, the more the symptoms improve. So that's in general the positive findings. And I usually say psychotherapy, the side effect is a better life. So people are always worried about medicine. What are the side effects? Well, with therapy, the only side effect is that you have a better life. Some of the negative findings about therapy is that community-based clinics are less effective than structured research therapy, which means that a lot of the models which have the research may not be applied consistently in actual community clinics the same way. So that's ongoing research that's needed to figure out how do we take the interventions that we do in research studies and make sure all clinicians are operating the same way. And that's our lecture. So let's stop there, and I will see you next week.